So it's a great pleasure for me to introduce the next speaker. It's Professor John-Anker Zwart from the University of Oslo and Oslo University Hospital. John-Anker is the leader of the FORMI research group at Oslo University, and also the leader of the Norwegian Musculoskeletal Network. He's a neurologist with a strong interest in pain, bodily pain, musculoskeletal pain, and headaches. And he's going to talk about chronic low back pain, susceptibility, risk factors, and future research. So please welcome John-Anker Zwart.
Ja, vi på nett nå? Ja, flott. Supert, tusen takk. Thank you very much for the introduction. Hello to you guys in Norway. I'm here in Sweden. So I'm honored to be invited to speak about this topic. It's challenging to follow up on Rachel's and Nadine's talk, of course, but I'm a neurologist from training. I'm actually used to look for a cause. I always think there is a cause for a pain, and we always look for the cause in order to treat it right. So the term non-specific doesn't really reflect anything that I usually try to accomplish in the clinical practice. But I'm going to go through a couple of things and maybe to challenge the papers in the Lancet, but I think they're very good, of course. But anyway, let's see what we can do to move things forward. So the thing is that the first issue is that this is the population in Norway from 1915, where you see there are very few elderly and a lot of young people. And then in the 1940s, we had less new children due to the war. Then the population increases, and also we had an older population that also will increase in numbers. In 2040, we will be almost all pensioners, and that will, of course, be a challenge, not only for low back pain, but for all types of diseases, and also the health, socioeconomic status, also the health government. Another challenge we have is that the obesity or overweight is increasing in most countries, most in the United States, but also in Norway. So we have this as a background. We know that the musculoskeletal complaints, chronic ones, they increase with increasing age. That includes also arthritis and other diseases, but we see it almost for back pain also most in middle-aged groups. We know that the BMI increases and the physical activity decreases. So these are the challenges, and this is from the Lancet papers, where we see that the disability for low back pain has increased, and it's during the most effective productive years we have working, and also among the elderly. So three fantastic papers in Lancet. I'm going to address a couple of things in those papers and trying to use that as a background. Why low back pain is and why we need to pay attention. Then comment shortly on prevention and treatment, and also pick out some things for the last paper, the call for action. After the series were published, there were also comments from other journals. This is from the British Journal of Sports Medicine that summarizes the things in those papers. It's a global challenge. It's not serious. We have limited diagnostic accuracy. Imaging is inappropriate. Non-pharmacological treatment is not advisable. Opioids, definitely not. Psychosocial factors are important, and we have to have a system approach and advocate the concept of positive health and need to change. So, you know, these are all the things that have been highlighted in the follow-up comments to these three papers. And this one is from Spine. where they definitely acknowledge the authors. They say it's a good first step, and the author deserve all praise for the fact that this is accompanied by a dissemination campaign. But the challenge is to transform this call for action into real change. I think that's the point. So let's go for the real change. Well, in the first paper, what low back pain is and why we need to pay attention, it states that low back pain is a complex condition with multiple contributors, both the pain and associated disability, psychological factors, social factors, biophysical factors, comorbidities, and pain processing mechanisms. And it states the vast majority of people with low back pain, it is currently not possible to accurately identify the specific nociceptive source. Okay, right. And from the panel one, you know, they point at one of the possible nociceptive inputs, like the intervertebral disc. The conclusion is there is no widely accepted reference standard for discogenic pain. For the facet joints, identification of individual whose facet joints are contributing to their pain is not possible. And for the vertebral end plate changes, like the modic changes, identification of individuals in whom modic changes are contributing to the pain is not possible. And the other table shows what you can see on an MRI. And we know from the Bowden studies in the early 90s, when the MRI machines came, that we find a lot of things actually in people that do not have any symptoms at all. So the specificity of these findings is questionable. That we totally agree. So the whole thing is these are kind of pessimistic background for starting. Why bother doing research on low back pain at all? Nothing helps. We have no evidence for anything. We can do some preventive measures and then move forward. So this is something I think it's we have to address it a little bit differently. So in my opinion, where do we start? Well, first of all, as a neurologist, there's always a cause for pain. We need a nociceptive input in order to feel pain. And if you look at this slide on the right, there are nerve endings that are triggered by different factors that sends the signal to the dorsal horn, and then that projects up to the brain. In the brain, it will be sort of disseminated to different areas that has to do with pain processing, but also mood and also attention and different things. So it's a complex mechanism handling the input of pain. And we have inhibitory pathways down from the brain to the spinal cord. So this is a very neat system where we have some that put on the system between the gas and the speed forward and the brake. So and how this then can change into what we call chronic pain, well, we don't really know yet. So nociceptive input necessary to understand that there is a cause for pain, but what happens next, that we have to challenge. So what we can do is that we can measure pain in sort of a way. What is then modifying the pain response? And one of the things, one of the ways to do it is to use a test stimulus where you actually provoke pain on one side, like on the right side there, with a machine, and then you can measure it and you ask the patient to rate it on a pain rating scale. And then after a while, you can ask the patients to put the other hand in cold water and then do the same test. And what you can see is that the test stimulus alone yields a higher pain rating than when you do what we call the test stimulus during conditioned stimulus, then the pain ratings fall. And the area in between we call the CPM effect, the conditioned pain modulation effect. That's a measure of how pain is modulated. It's a measure. The challenge is that these measures we have challenges with repeated, doing the repetitive measures in the same patient differs. between patients differs. We don't know what the prognostic value for instance, low back pain is, and either not in pain patients either. So it's a way to start the process to work on it, but it's not totally valid yet, this method. Other studies look at how these pain mechanisms are processed in the brain. And the way to do that is to use, for instance, gray matter analysis. And on the left side, you can see that there are reported reductions in the gray matter in the areas that are involved in pain perception and modulation in patients with chronic back pain compared to controls. On the other side, we have what we call the connectivity. So that is, you saw the different areas, how they communicate with each other, all those that are involved in processing of the pain. That involves also cognition, attention, mood disorders, and support. That is also different in patients with chronic low back pain versus controls. We see these patterns also in patients that are depressed without any pain. So what is very difficult to say. So it's closely related to other diseases or disorders. But one of the good things is that if you do a follow-up study of patients that proceed, from an episode of acute low back pain, and those that will have persistent pain over time, you can see these changes are sort of emerging. But among those that have acute episode and then revert to normal, get pain-free, then these patterns revert to normal. So it seems to be a reversible pattern. That's good. So then we have a lot of things that have also from the paper, symptom-related factors like disease duration, important for the as a prognostic factors. Lifestyle factors, body mass index, smoking, physical activity, psychological factors, depression, which we also see the patterns as I saw for the functional MRI studies and the connectivity studies, catastrophizing, fear avoidance, all these things, and physical workload, education, compensation. We know this, the evidence for this has been presented. So for the body mass index, these are some data presented from Ingrid Høeg's work based on the population-based studies that support that body mass index and increase in weight does affect the risk of developing chronic back pain. And there is also association with other cardiovascular risk factors, lipid levels, and so forth and so forth. And it seems that smoking has an impact also on the chronic low back pain and also musculoskeletal pain in general, especially evident from this study for those that are younger than 50 years of age. It seems to disappear after 50 years. And physical activity load also relevant for women and men. And so all of these things actually are very well summarized in the paper that lifestyle factors, smoking, obesity, low levels of physical activity, poor health associated with low back pain episodes, and demanding jobs, physical and mental comorbidities, smokers, obese, are the greatest risk at reporting low back pain. And those with low socioeconomic status. This is actually what we also see, for instance, for cardiovascular disease. It's the same thing. Same risk factors. Same risk factors for other diseases as well. So what we could do is, okay, we can manage these, use this as a background and start what we call stratification studies, really interesting studies from Kiel, where you can see that you have a different approach for treatment based on these factors. And then you select people and you give them target treatment. And that seems to be effective. That is also something that can be implemented in primary care settings. That's fine. But for cardiovascular disease, we also measure blood pressure, which we also measure lipid levels. I mean, we also assess different, what we call modifiable factors actually that are more biological, not only the psychosocial factors. So we could, of course, by doing this for cardiovascular disease, prevent probably cardiovascular events or cerebrovascular diseases, but not for all. We have to add, control of the blood pressure, lipid levels, and stuff like that also. So I think we should approach that also within the low back pain care. This is fine, but I think we can do a little bit better. Because we know, per se, this was, Nadine showed that's exercise and in combination with education, that's the only thing that works actually. But we have to, I think we have to look for something else. Are there some other biomarkers? Are there something else that actually can provide us with extra knowledge about what kind of preventive measures we can do in order to prevent chronification of pain, for instance. So if you go back to the genetics, because that is also mentioned in that paper, genetics, we know that the heritability of low back pain is approximately 34%. That means this is a non-modifiable factor. We can't do anything about it. We're born with it. So this is something we have to address. Why is it? It's not only environmental. It's definitely some genetic component that affects the susceptibility to develop chronic low back pain. So if you look at it, just as an introduction, we have DNA string, and then we have what we call the base pairs. And the combination of these base pairs, they define the proteins, and the proteins then are the one that sort of have the effect in the body. So this we can address, for instance, in different pain disorders. These are really rare pain disorders that are either dominant or recessive, and then we can use what we call linkage analysis to figure out whether there is a mutation in the calcium canal or any other depletion in somewhere that have a specific phenotypic description. So the phenotype can resemble some deficits in other parts of this genetic mapping. But these are really rare and not very, we cannot use this for the more common disorders like common low back pain, even though there are some candidate gene studies done, of course, a lot of them, like this, these two, for instance, the one that has assessed the COMP gene that we assume has something to do with pain processing. And it seems that when we follow sciatica patients up over a period of 12 months, there is a difference in the COMP, the val-val versus the met-met variation of that gene in relation to persistence of pain. That also accounts for the opioid receptor, and there's a difference between genders. But these candidate gene approaches are not very robust, and it's hard to replicate them. So that's why they move over to what we call the genome-wide association studies, where we have a bunch of cases and a bunch of controls, and then we merge everything together, and then we analyze the frequency of different SNPs in the case group versus the control group. This is something we have done in migraine, for instance. This we started 10 years ago. And this is the recent one, I think. But what we see is on the x-axis are the chromosomes, and on the y-axis the p-values. So we define a p-value above -8 as significant, and those a little bit below as suggested. And what we can assess here are the autops of different SNPs that are associated with the genes, and then we can see what type of genes then have an impact on migraine. And we can do network analysis in order to see if they impact each other. For instance, in this study, we see that there are some genes that regulate the synaptic activity, vascular function, nociception, and specific glutamate homeostasis genes. All these genes can be put into sort of a network analysis. Then we can see, oh, these are some regulate, some modify, some response, but they all end up with a sort of oxidative stress. That might be relevant, of course, in the migraine pathogenesis. So what has happened within the chronic low back pain field? Well, there's one GIVA study that actually report for one significant hit and 3 suggestive. This is interesting. The thing is that these studies require enormous amount of cases and controls. So this has to be increased. So we should focus upon, combining our resources and combining the collaboration with different countries in order to increase the sample size, to see if we can find more significant SNPs that might give us some input on how the genetic architecture works in low back pain. Another aspect is that the epigenetics seems to play an important role in in chronic pain. Epigenetics, the DNA is modeled around histones, and methylation groups sort of regulate the expression of different genes. So if you have a pain gene, it might be sometimes opened up by, the methylation might close it, or demethylation open it. So you get the transcription of a pain gene. That might be relevant for why some people develop chronification. And we have made a special video on how to describe what is actually epigenetics. It's an informative one to show that environmental factors actually play a role in altering the epigenome. We have assessed this, for instance, for development on chronic headache, and then we see that the methylation changes. We see that is associated with headache chronification. And this is something we also have to address in development of chronic low back pain. So one of the things we should do in future research is to look at the genomics, epigenomics, and gene expression, combine these together and with environmental factors in order to see what the impact of the genes versus the environment, how this will influence the epigenetics and the gene expression. This might give us an input on what are the pathophysiological mechanisms, and maybe additive also add something with respect to biomarkers that might be useful in addition to what we know about the psychosocial factors. So this has to be done in large population-based studies, replicated, and we have to do follow-up studies with respect to the epigenetic mechanisms. So, for instance, for arthritis, that's pretty, as an example, they have, assessed that in detail. They looked at different biomarkers for arthritis. There is an inflammation that continues, and then you get a degradation, and then you have a process going on with a lot of inflammatory things going on, and they have this is from a publication that sort of justifies that looking into genes in relation to the other environmental factors is actually important to understand why you have pathogenesis of osteoarthritis. And this is a way to do it, is that you can sample inflammatory markers. You can take from normal blood samples. Then it's from osteoarthritis blood samples, osteoarthritis synovial fluid, from rheumatoid arthritis, and rheumatoid arthritis synovial fluid. And the more sort of amount or intensity of these inflammatory markers are illustrated in red. So what you can see that, of course, rheumatoid arthritis is a more active inflammatory disease system, active disease than osteoarthritis. But you can also measure these changes in inflammatory mediators in the serum from osteoarthritis. And this is something we also could do for low back pain. We can also assess whether there are differences in expression of inflammatory markers for instance, back pain. And we can also look at the expression of the upregulation or downregulation of the effector genes or the inhibitors in order to understand the pathophysiological mechanisms. For instance, the clinical trials, even though one might argue that doing surgery is, there's no evidence that it works, but there are some interesting aspects from these studies that we should take into consideration. There are specific subgroups that might be highlighted, and that we can use this information also to understand the pathophysiological mechanisms. This is from a study, a randomized study using rehabilitation versus surgery, disc surgery. And you can see, you can read about these results, but that's as an example. This study has been followed up for 2 years and also for 8 years. And we all know that the predictors after success is, of course, they have low distress, not using narcotics, have a low fear avoidance, that they have a high score at baseline, a level of education has important. All these things we know from before. So this is just a confirmation of what we already know. But one of the interesting things here is that MODIC, the patients with end plate changes, they seem to report, were more likely to report a clinically important functional improvement. And that is something, the study was not designed to assess that, but that's an important information. And with respect to the study that was done in Denmark on antibiotics, that actually shifted a little bit the approach with respect to patients with chronic low back and MODIC changes. It must, of course, be replicated and in randomized controlled trials. And we have recently, on the right side, the trial that Kjersti is responsible for. We have recently ended the follow-up data, the one-year follow-up data from the last patient. I think it was last week. So we are very curious, and we have already set the statistical protocol and written 3 different versions of the manuscript. So we are going to break the code, hopefully, when everything is set. So we will see. We do not know whether the potential effect of antibiotics is related to the anti-inflammatory effect or the antibacterial effect. And that is one of the theories that has been launched by also patients. We have made a specific MODIC movie for the patients to look at YouTube, where we have sort of the mechanical cause, the autoimmune cause, and infection cause. And the autoimmune cause is one that we are going to start with, to actually use TNF-alpha blocker in the same randomized control setup, placebo control, to see if that's something we have to sort of try to move on and try to understand what the pathophysiological mechanisms are. And there might be differences in genetic susceptibility, whether or not these people develop pain or respond to treatment. So all in all, I think it's important to have a more broad concept of low back pain. I think the genetics, the genotyping, gene expression, epigenetics, pain modulating profiles and detection, and taking into account also associated disorders and comorbidities is, of course, really important. And more detailed pain phenotyping using different sort of tests, as I referred to. And clinical studies, information from clinical studies, also very important to have in the picture in order to figure out how we can predict why some patients develop chronic pain and chronic low back pain. So I'm going to end with Rachel's comment. The importance of behavioral approaches to back pain management does not preclude the continuing need to investigate mechanisms and potential biological determinants of non-specific low back pain in phenotypically distinct subgroups. So that was it. Thanks.
Thank you very much, John-Anker. We have some activity on the internet before we start with questions or comments from the audience this time. Please.
Hans Tropp, I'm a spine surgeon here in Linköping. I just wonder, what's the definition of non-specific low back pain?
You tell me. You know, that's why I started saying I don't think that's a very fruitful term, non-specific. I think there's always a cause. It's just that we haven't found it yet.
But according to these different nice publications, I suppose that there have been some kind of definition of what's the non-specific low back pain.
Yeah, maybe the authors of the Lancet series can comment on that.
Well, I was first author on the paper where we defined it, but I don't know the specific wording. I don't remember it. It was a long time ago now, but it's the symptom of pain in people with no immediate identifiable cause that we can find. So we call it non-specific. It's a symptom.
Okay.
I just think it's important that we don't communicate that the use of non-specific. I can agree that it's not a very good term, and especially it's not a good term in communication with patients. But I don't think, and I also don't think we suggest that in the Lancet papers, that non-specific means that there is no cause. It's just that we cannot identify one specific structure, and it's more complex than down to one structure. And also that it's often not important to patients that if it's a facet joint or a muscle or a disc, because they have a good prognosis and there are things to do that give them a positive outcome. So I think it's really important that non-specific does not mean there's no cause. It's just not one specific structure that is identified.
I agree. I agree. So it's but the thing is, you know, if it develops into chronic pain state and it has a disability aspect, and the patients seek the secondary healthcare to get, we have to search for. But for those that revert and acute back pain episodes, usually have a very good prognosis. So that's fine.
I think it's very important to distinguish between pain and disability. They're two quite unrelated concepts. Anyways, we have more than one microphone, don't we? Yeah.
Among spine surgeons, that type of operation is a very good operation because we have good results. And usually we use the MRI to detect what is the painful segment. And if we are successful to clinically provoke the pain from that segment, and the other segments are not degenerative at the MRI, we have nice results. We don't know whether we could have the same results from some other treatments. Your Norwegian studies give some good result, and the non-surgical treatment is good, but not as good as the surgery. The problem, I think, is that a lot of patients have these MRI findings without the same clinical picture. And I think it would be nice if you could find some methods to define or diagnose if this just is what we call clinically a segmental pain, a mechanical pain, a mechanical provocable pain without any rheumatoid subdiagnosis or something like that. So it's a good model for further research, I think.
Okay, we have a question from the internet, and there are a couple of questions that relate to children and adolescents that I think is a very important area that we'll talk about after lunch. But
yeah, I think I will start with the other one because it's related to the last speaker. And that is from Daniel Andreasson. There have been RCTs on operation versus sham operation on knee and shoulder that shows no significant difference in outcome. Why would that differ from low back pain?
No, it should be done. I agree.
There has been done some very good trials on that as well. Mm.
We can take one more.
the second one also, and that is quite a long question regarding children and future low back pain. But I think you might have. I prefer to ask it. What are the variables, risk factors that correlate better with future low back pain? And I think he's asking in particular for children and future low back pain. I thought about the Hunt studies. Can I continue? Or would you? Yeah. In terms of more functional assessment, muscle endurance, hip mobility, for example, is there any variable that stands out? On the other way, is there any variable that, in a more surprisingly way, research has shown clearly to not correlate at all with low back pain? Thanks. So maybe we need to help him.
Yeah, I think I need some help there. I can address the one based on a study from the Young Hunt, looking at different sports activities and physical activity in relation to pain and also mental health. And it seems that the physical activity decreases in the videregående skole, what you call that? Secondary, well, from 16 to 18 years, usually decreases. And then you also get the increase in the number of what we call the mental issues and also pain issues. So it seems that there is good evidence to suggest that keeping up the physical activity level seems to protect the development of pain-related and chronic back pain-related symptoms. And also that it gives more self-esteem and more, you know, what we call the psychological flavor of the pain issue as well. Yeah.
There is one. Can I continue?
Anyone here has a comment? Yes, please.
Yes, I had a question regarding what you said that as a neurologist, you think that always have to be some activation in the fibers in order to have pain. But we know that imagining pain and fear of pain can give the same activation when you look, for example, in fMRI studies, as just imagining it can give the same as physical pain.
That's right. But,
Yeah.
the imagining, it reflects in functional MRI studies. That's what I meant, that it's related to mood disorders, cognition, it's attention. All these areas talk together. And if you imagine the worst pain you ever had, you also get the activation. So it's unspecific. That's my point. That was my point. Yeah.
And also, I'm also in the biomarker field of pain, but many times I wonder, like the study you showed with knee osteoarthritis,
Yeah.
Is it biomarkers for pain or is it for inflammation and nociception? And then again, it doesn't correlate maybe to pain, even if you find those biomarkers.
Yeah, that's true. That's true. I agree. Good comment.
Okay, we have activities from the web. Pain, by definition, is an emotional experience. It is increases over decades. Are we genetically changed in this period? If not, why do we have to do research on it?
Well, we are born with the genes, can't do anything about them. Environment it has the large proportion. I mean, the heritability, but the environmental factors is definitely the most important thing to consider if you have to live with pain and also pain. But it has an impact also on a genetic profile and expression. That the point was, we have, in order to understand the mechanisms, that's one way to approach it.
Thank you. That's it from the net web for now. Yes.
My name is Berit Schøtz-Christensen from the Spine Center of Southern Denmark. I really enjoy this discussion, and I enjoy it because when you read the papers, you are getting really thoughtful, and then when we discuss, then it's getting even worse. And I want to raise one really important topic from what you said, Jan, and that's first of all, we think as clinicians that it's important that we are calling it non-specific low back pain. But what about our users, our patients? What do they think? We have done some studies on that, and we have actually asked the patients, what do you think about having the diagnosis non-specific low back pain? And they actually hate it. That's one question. And then not a question, there's a comment, and you can comment on that too. And then another one, we are always talking about pain and the grade of pain. What about disability? When do we start talking about the whole patient, talking about how much pain, how much disability, how do they function in the daily life? When do we change in that direction? I think that'll be the next step.
Yeah, I agree. With respect to the last question, that is actually what you do in clinical practice. You know, they present with pain, and then you say, okay, how bad is it? What can you do? What can you not do? You know, does it affect your work, leisure activities, in order to sort of get the impression of how actually affected they are? And that I think that is something you do in clinical practice. And I agree, it should put emphasis on that. It's important. With respect to the other one, then what the patients mean, I think that's important to consider, because they usually feel that it's sort of a stigmatizing box called I'm a non-specific. If being I'm an alien, I'm a non-specific. You know, it's easier for them to relate to some kind of a different wording. So I usually don't use that when in clinical practice. I don't use the word you have non-specific low back pain. There's no future. You have to train. You know, that's you try to explain the pathophysiological mechanisms. You know, education, and you say, okay, and the way to do it is do it this way, but then they relate to something. Yeah. No.
Yes, I have a short question about the study you were talking about regarding pain modulation profile or the condition pain modulation. I didn't get it really if that was something that was done on could you see a different effectiveness of the condition pain modulation in people with long-term low back pain, or was it something that you could, was it predictive of getting?
Yeah. The window you see between the precede pain and the after condition stimulating, that's what we call the CPM effect, condition. But it's among chronic pain patients, that one is not, it's not that wide. So they don't get that inhibition in the same, we don't see the same pattern in those with chronic pain. But whether it has a predictive value, that's more questionable.
Okay, thank you very much. This concludes this session. Thank you very much, John-Anker, for an excellent talk. Now,